is Travis Freeman. I'm the director for the Morgan County Ambulance Service in Fort Morgan, Colorado. Thank you for joining us for this basic EKG class. This class is designed to help you understand the physiology of the electrocardiogram, how the heart works, and how to recognize different EKG rhythms in hospital and in the field if you're a pre-hospital provider. If you're wondering about the textbook that we're going to be using for sessions 1, 2, and 3, we're looking at the Rapid Interpretation of EKGs, 6th edition. We're not sponsored by any specific author or publisher. This is just a good book for us to use that's easy to understand. If you have any questions at any point, please don't hesitate to contact me via phone at 970-542-3570 or by email at tfreeman@co.morgan.co.us. Again, thank you for joining us, and we hope you enjoy this class. Chapter 1, Basic Principles. So most of us have some sort of medical background, either in nursing, respiratory therapy, paramedicine, pre-hospital. So as a reminder, I have a photo of the heart just so that we can recognize the different main areas of the heart. So we have the superior vena cava next to the aorta and the aortic arch. We have the pulmonary trunk, the right atrium, the left atrium, the right ventricle, the left ventricle, the tricuspid valve, the bicuspid valve, the pulmonary semilunar valve, and then the aortic semilunar valve right here. The inferior vena cavas down at the bottom, as well as cardiac muscle, which makes up the entire heart. So if we were to follow a drop of blood through our heart, it would make many different turns. So the superior and inferior vena cava are two pathways that bring blood back to the heart, bring deoxygenated blood back to the heart. So it brings the deoxygenated blood into the right atrium. It drops through the tricuspid valve, up through the pulmonary valve into the pulmonary artery, and again, this is deoxygenated blood that takes it back to the lungs so that whenever we breathe, this blood can then be reoxygenated. Now, when it comes back, it's coming back through the pulmonary vein into the left atrium. The left atrium then is going to drop it through the mitral valve and take that oxygenated blood from the left ventricle through the aortic valve, through the aorta, to supply the rest of the body with oxygenated blood. So again, superior and inferior vena cava to the right atrium, drop down to the right ventricle, up through the pulmonary arteries into the lungs, bringing that oxygenated blood back through the pulmonary vein into the left atrium, dropping it down into the left ventricle, and then supplying the body with oxygenated blood through the aorta. Now, our coronary arteries are what is actually supplying oxygenated blood to our heart. Again, our heart is a muscle, right? So we need to supply oxygen to our muscle. So whenever the aorta is being pumped with blood, the oxygenated blood, we have our coronary arteries, our right coronary artery that is on the right side of the heart, the left main, the circumflex coronary artery, and the left anterior descending. So if you think about the right coronary artery, you're thinking about the right side of the heart. The left coronary artery is the left, and then the left anterior descending is going over the front of the heart to supply the heart with blood. So again, from the left ventricle up through the aorta into each of these coronary arteries to supply the physical heart with oxygenated blood. So the basic principles of an EKG. EKGs, as we tell people, we're taking a picture of their heart. We're not actually taking a picture of their heart. We're taking a photo or recognizing the electrophysiology that is actually making the EKG. So the electrocardiogram, or the EKG, records the electrical activity of the heart, and it gives us information about the structure and function. So we want to know how this electricity is moving through the heart. This gives medical staff like us different views of the heart that gives information on the issues with the patient and how they need to be treated. And the EKG shows the contraction of the heart and the myocardium. The myocardium is the heart muscle, and this also provides us information on rate, or how fast the heart is actually beating. The muscle of the heart, or the myocytes within the heart, are polarized or negatively charged. So when it's depolarized, the myocytes contract. So here in this picture on the left side, you can actually see the resting membrane. And whenever it's depolarized, that muscle actually contracts. So the heart is at rest whenever it's polarized, and when it becomes depolarized, or it's positively charged, the heart contracts. As the heart depolarizes in a wave, it causes the muscle of the heart to contract, and this should start in the right atrium. So remember, going back to those photos that we just discussed, we have contraction beginning in the right atrium and working its way towards the lower left. This is caused by sodium ions within those myocytes. So as the process of positive and negative charged myocytes take place, we start to see this EKG tracing, the actual lines on the paper. Immediately after the cells depolarize, they begin to repolarize. So when we look at somebody's EKG and we have a beat after beat after beat after beat after beat, this is happening very quickly, where the myocytes are polarized, depolarized, polarized, depolarized, polarized, depolarized. And they go through this constant cycle so that our heart can actually function and beat. So whenever we look at an EKG here in just a little bit, if we're looking at the pointy part, like here, this R wave, this is depolarization. Now whenever we have a short wave that's kind of rounded, this is repolarization. So this is the heart contracting. This is the heart relaxing and getting ready to recontract. So we know that we put sensors on patients' skin, and they detect the electrical activity within the heart and the movement of the ions through the heart. So when we put these stickers on, we can actually print these tracings and actually see how the heart is functioning. They're very sensitive, and they're attaching the cords to the skin through these electrodes so that we can actually see the tracing and the electricity. So again, a positive electrode is an electrode that is actively recording an EKG. So you have positive and negative, just like we have positive and negative ions. You have a positive and negative electrode for this EKG. The positive wave of the depolarization follows a positive electrode, and there's a positive deflection recorded on the EKG. So if you look at this picture right here, this myocyte right here is now depolarizing, right? So it's contracting, and it's contracting in a way towards this electrode. So if you start to see a positive deflection on the EKG, just as you do here, that means the heart is contracting towards that electrode. The movement of the myocardium is a wave of positive charges. So when there's a wave on the EKG and it's positive, you know that the depolarization is happening towards that electrode. So keep that in mind for later whenever you're looking at EKGs and kind of understanding how the heart and the myocardium is contracting. So the heart starts with the SA node. Okay, so keep this in mind. The SA node, or the sinoatrial node, is located in the right atrium, and it's the heart's first pacemaker, and this is where depolarization begins. it creates what's called a sinus rhythm, and you're going to hear sinus rhythm throughout your entire career in medicine. It is in the upper posterior wall of the right atrium, and it takes pacemaking responsibility. This is known as automaticity. So it is firing at its own rate between 60 to 100 beats a minute. And when the SA node sends a signal for depolarization, that depolarization then is going to take place through the remainder of the heart. So if you look at this video here, you can see right up here, this is where the SA node is, and it's firing, 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 firing. And it's sending these signals very quickly through the rest of the heart so that the heart can contract. So again, take from this, the SA node is number one. Every time the SA node depolarizes, again, it's sending those signals down the heart, creating our first wave on the EKG, the P wave. So the P wave is a positive wave in this scenario, and it represents the atrial depolarization that happens simultaneously. So the atria are firing, the SA node's firing, and it's causing depolarization through the right and left atria at the same time. So when you see this P wave, just know the atria is firing and pushing this blood that's in the atria down into the ventricles. So again, P wave, positive, okay? So it's starting in the SA node, firing across these membranes, and then pushing this blood down into the ventricles. The AV valves prevent backflow or blood to back up into the atria. If we didn't have the tricuspid and mitral valves separating our atria and our ventricles, when the ventricles go to fire, it will pump blood back up into the atria, which we absolutely don't want. So the atrioventricular valves prevent backflow. The mitral and tricuspid valves are between the atria and the ventricles, and they prevent the electrical activity to pass through the ventricles. So if you're looking at both of these, you notice that there's another node right here, right? What was that first one that I told you? The SA node. So now we have the AV node. The AV node, or the atrioventricular node, provides a signal pathway or a single pathway for the electrical activity to get from the SA node through the atria to drop down into the ventricles. So the tricuspid valve, again, is on the right side. So I like to think tricuspid, right, RI, RI. And then after the ventricles fill with blood, the tricuspid valve closes. So as the atria is pushing that blood, those valves are opening, and then whenever it's stopped, it's closing again to prevent that regurgitation up into the atria. The bicuspid valve, you guessed it, is on the left side. The oxygen pure blood enters from the lungs into the left atrium, which then passes through the bicuspid valve into the left ventricle, and then all other areas of the body through the aorta. So again, starting with the right atria, deoxygenated blood is dropping down through the tricuspid valve into the right ventricle. As the ventricles contract, it's pushing that deoxygenated blood through the pulmonary artery to supply the lungs with deoxygenated blood, so that as we breathe, we can reoxygenate that blood. It can come back to the left atria, drop down to the left ventricle through the mitral or bicuspid valve, and then be pumped out through the aorta to the rest of the body as the ventricles contract. When the atrium contracts, the AV node allows the electrical conductivity to slow down, allowing for the ventricles to fill with blood. If we fired the ventricles at the same time that we're firing the atria, blood is not going to go anywhere. It's just going to sit there. So it's important for the atria to fire through the SA node. The AV node here is slowing down this conduction just for maybe a second, 2 seconds, and it's passing through. Okay, so very, very quickly is the AV node slowing down, but it's allowing for the ventricles to actually fill with blood so that the blood is not just sitting here. So again, SA node fires, AV node slows it down, and as it passes through, it's slowing it down and sending it through the left and right bundle branches and Purkinje fibers. Okay, so I know this is a lot, but SA node, AV node, bundle of His, left and right bundle branches, and Purkinje fibers. Okay, that's all you need to know about the pathway. SA, AV, which slows it down, right? Bundle of His, which is honestly just a pathway to get down. And then the left and right bundle branches that branch off into these tiny, tiny, tiny Purkinje fibers that are allowing the ventricles to get some type of electrical activity. So once at the bundle of His, right? So we've gone from the SA to the AV. Now we're at the bundle of His. The electrical impulse branches off down the septum. So our septum is what is separating the left and right sides of the heart, right? So you have the septum here, and it's separated. So we can't go straight down the center of the septum. We have to have the left and right bundle branches. When the electrical impulse reaches the Purkinje fibers, it allows for that rapid depolarization into the ventricular myocytes, right? So already we've gone from the SA node to depolarizing the atria, right? Now we've given the ventricles time to fill. The impulse is passing through the AV, through the bundle of His, through the bundle branches, through the Purkinje fibers, and now the Purkinje fibers are contracting because of that electrical impulse. Now remember when we said that if we have a positive deflection, the pathway is going towards that electrode? Now we have a negative deflection. The Q wave is the first downward wave of the QRS and is followed by an upward R wave that is sometimes absent. So sometimes you're not going to see a Q wave. Sometimes you're just going to see a PRS-T. Okay, so again, P is atrial depolarization. Then you have QRS. And again, the Q wave is the first downward wave of the QRS complex. The R wave is then followed by the S wave, which completes the QRS complex and represents ventricular depolarization. So the big piece of the QRS complex and the QRS complex itself is ventricular depolarization. So if you're having a hard time determining the downward deflections as Q or S, just look for the R wave and determine if it's before or after the R wave. So again, alphabet Q, R, S. And if you don't have a Q wave, you're just going to have P, which is that little hump that we saw earlier with atrial depolarization. So P, R, S, and then you'll eventually have a T. So again, QRS. Which one is which? I'll let you decide. Number one, this is a downward deflection. Let me go back. Excuse me. Number one is a downward deflection, so this is a Q. Number two is an upward deflection, so that's an R. Number three is a downward deflection. which is an S because it's after the R wave. And then number 4 is QS. The line right after the QRS is known as the ST segment. This segment represents ventricular repolarization. This point on the QRS may be elevated or depressed, but is most often flat. So you have this plateau phase here, which is your ST segment. It's the time between your S wave and your T wave right here. This is ventricular repolarization, where your ventricles are repolarizing and getting ready to contract again. The final wave after the QRS is known as the T wave. This is what I was talking about. So again, you have that small hump at the beginning, which is your P, QRS, T. See how we're following along with the alphabet? It is the rapid phase of ventricular repolarization. Repolarization occurs so that the ventricle myocytes can recover their interior resting negative charge so they can depolarize again. We don't really see this with the atria. Remember, the atria here are depolarization, and we don't see repolarization of the atria because it's covered up by the QRS. So the QT interval represents the duration of ventricular systole and is measured from the beginning of Q to the end of T. So again, this is during the entire phase from beginning of Q to end of T. This is your QT interval. The cardiac cycle. The entire cycle itself is represented by the P wave, the QRS complex, and the T wave. This is repeated time and time and time and time again as long as somebody's heart is still beating. Atrial depolarization is represented by the P wave. Ventricular depolarization is represented by the QRS complex. Thanks for joining us again after a quick short break. This is chapter 2 of our basic EKG class, recording the EKG. So again, looking at the layout of the heart, here is just a reminder, the superior and inferior vena cava, which is bringing blood back to the heart, that's dropping it into the right atria. This is deoxygenated blood that the body's already used. It's dropping it down into the right ventricle, up through the pulmonary semilunar valve, into the pulmonary arteries to supply the deoxygenated blood to the lungs so that when we breathe, we can reoxygenate it. It's coming back into the left atria, dropping it down through the mitral valve into the left ventricle, which is then going to pump the blood through the aortic semilunar valve, through the aorta to the rest of the body, and that is oxygenated blood. The pathway of blood through the heart again, as it follows, like I just said. Our coronary arteries. Recording the EKG. So the EKG is recorded on paper that is in a strip and divided 1 millimeter high and 1 millimeter long, which are the small boxes. The big boxes are measured 5 millimeters high and 5 millimeters long. So here you can actually see where we have the big boxes, and this is zoomed in to create little boxes. So the big boxes again are 5 by 5 millimeters, and the little boxes are 1 by 1 millimeter. So the height and the depth of the wave measured vertically represents the voltage. So if we're looking at this picture, we have 3 millimeters high, 2 millimeters deep. This is the voltage. The first wave to the left measures 3 millimeters and 2 millimeters deep. And if there is elevation or depression of segments from the baseline, then this is also measured in millimeters. So when we're talking about our isoelectric line, we're talking about the baseline. This is where everything comes back to that resting straight flat line. And our baseline, again, positive down to negative. And when we talk about a positive deflection, the myocardium is actually contracting towards that electrode. So again, thinking about the piece of paper, these are measured in millimeters. Up and down is our voltage, and then right and left is time. The horizontal axis is also measured in millimeters, and each small box is 0.04 seconds. This is important to remember. 0.04 seconds. Every 4 small boxes is 0.16 seconds, and each large box is 0.2. So again, going back to, remember when that piece of paper is 5 by 5 millimeters? 5 millimeters long is actually 0.2 seconds. This is important to know when we discuss the duration of the EKG complex and the QRS complex, along with the heart blocks and arrhythmias that we'll discuss later. But again, up and down is voltage, right and left is time. Okay, there's a total of 12 leads on a standard EKG. There are 6 limb leads and 6 chest leads. So you have your limb leads as 1, 2, 3, AVR, AVL, AVF. And our chest leads are V1, V2, V3, V4, V5, and V6. The limb leads are placed on those corresponding limbs. So if you have a chance to actually look at EKG chords, you're actually going to see those limb leads, and you're going to see LL, LA, RA, RL, and those represent right arm, left leg. So we're placing these actual limb leads on those limbs. Our bipolar limb leads record using 2 electrodes that make a pair. We have to have a positive and a negative electrode to be able to create these bipolar limb leads. Lead 1 is horizontal. So again, going back to lead 1, lead 2, lead 3, AVR, AVL, AVF. That's what we're talking about right now. So when we're talking about lead 1, we have a negative electrode here, positive electrode on the left. So the left arm is negative while the right is positive. When looking at lead 3, the left arm becomes negative and the left leg is positive. So if you think about this, the way that the EKG is actually reading, lead 1 is looking at a camera perspective of how the myocardium is actually moving across those cells towards that positive electrode. Again, lead 2 is from right to left. So if you can see me, we're looking at lead 1, lead 2, which is diagonal, and lead 3, which is downward from the left arm to the left leg. So AVF uses the left foot as positive and both arms as negative. AVF is a combination of leads 2 and 3. And the remaining leads, AVR and AVL, are similar in that with AVR, the right arm is positive and the 2 remaining are negative. So AVR, AVL, AVF, easy way to remember them. AVR, our arm is positive. So AVR, your right arm is positive. AVL, your left arm is positive. And AVF, your left foot is positive. So looking at this, again, 1, 2, 3. And then AVR, your right arm is now positive. AVL, your left arm is now positive. And AVF, your left foot is positive. Again, the positive leads whenever you have a positive deflection, we're looking at how that myocardium is moving towards the positive lead, okay? The augmented limb leads, AVR, AVL, AVF, intersect at different angles and give different reference for us. So I know this is a little bit confusing. These are called augmented or unipolar leads. So now we have 1, 2, 3, okay, AVR, AVL, AVF, and we're actually creating intersecting limb leads on the standard EKG. All these limb leads meet to form those intersections, and the bipolar leads, 1, 2, and 3, the unipolar leads AVR, AVL, AVF. Okay. So again, bipolar, you only have 2, positive and negative, and then unipolar, you have a positive and 2 negative. Each camera position represents the positive electrode. This is the view at which we're recording the electrical activity. So if you're looking at lead 1, for example, we have a camera here and looking at how the electricity is moving towards that camera. Lead 2, same thing. We're looking at how the electricity is moving towards that camera. Lead 2 is one of our more common leads that we're going to see. On the monitor, this is one that the EKG actually starts with is lead 2. Lead 3 is the same way. It's going to be looking towards this camera. AVR, looking in a backwards way. This looks at all of our main arteries and veins and parts of the heart that are large on the inferior portion. AVL, same thing, you're looking towards that camera. AVF. So if you look at this photo of this car, you're looking at the same car at 6 different views. This is how the bipolar and unipolar leads are working together, and this is kind of how we're looking at an EKG. The car represents the heart, and we're looking at it just from different angles, seeing how the electrical activity is moving through the heart. So the importance of the positive electrodes positioning is the grouping of the leads. As you can see, the lateral leads are 1 in AVL. The inferior leads are 2, 3 AVF. And we need to remember which leads are which. Okay, so your lateral leads, lateral meaning side, and then inferior leads are 2, 3 and AVF. Inferior meaning kind of the bottom of the heart. So you have your lateral over here, and then your inferior leads where your cameras actually are at. Our chest leads, we were talking about V1, V2, V3, V4, V5, and V6. We need to place all of these in 6 different positions. We're placing them progressively around the chest, and these are all positive leads. We're essentially wrapping the leads around the heart for different views. Okay, so we have V1, V2, V3, V4, V5, and V6 that's wrapping around the left side of the chest. Okay, so again, V1, V2, V3, V4, V5, V6. Then we would have a left arm here, left leg here, right leg, and right arm to create all of our 12 leads. The electrode is always considered positive during your V1 through 6. So when you place V1, V1 is now your positive electrode. Okay, I place this on the chest. Same thing, V2, V3, V4, V5, V6. Your negative electrode, you don't have one. Okay, so your negative point is actually the heart. And when we put V1 through 6, wrapping it around the chest, V1 through 6 are all positive electrodes, right? So your negative portion or your negative electrode is actually going to be your heart. So it's looking at how the heart is pushing that electricity towards V1 through 6. So you can see V1 is primarily a negative deflection, and as you get towards V5 and V6, you actually have a positive deflection because of the way that the electricity and the myocardium is shifting through the heart. Okay, so again, positive leads are going to be those leads that you're putting on. Your negative is going to be the heart. So when you place V1 and V2, they're directly anterior to the heart. These are separated by the sternum. So we're placing these on either side of the sternum. V5 and V6 are directly lateral to the heart, so kind of under that armpit area, and the depolarization towards V6 through the myocardium causes that positive deflection. Again, most of our electricity is moving away from V1 and V2 because it's moving towards that inferior portion, or V5 and V6, right? It goes at kind of a sideways angle. So V1, V2 are up here. If our deflection is going this way, we're actually moving away from V1, V2, so those should be negative. And V5 and V6 should be positive because the electricity is moving towards them. V3 and V4 are over the intraventricular septum, and V3 is near the right ventricle and V4 is near the left. So the septum, remember what's separating the right and left ventricle, okay, where our bundle of His, bundle branches, and then we start getting those Purkinje fibers. V3 and V4 are actually sitting on the septum, so those are your septal leads. So again, your limb leads 1, 2, 3, AVR, AVL, AVF, those are you're going to get all 6 of those views simply by placing left arm, left leg, right arm, right leg. But you're actually not going to get V1, V2, V3, V4, V5, V6 without placing each of those leads on the chest and then going around the heart. The 6 limb leads form the frontal plane, while the chest leads create a horizontal plane. So if you think about a camera, I'm looking directly at the heart, okay, with my 6 chest leads. If I'm looking at the limb leads, I'm looking at it kind of from a backwards perspective, looking at how the electricity is moving through. So the 6 limb leads can be positioned on the trunk as well. This can help decrease any artifact. Artifact is something like if we were in the back of an ambulance, for example, and we're driving down a bumpy road, we're actually not going to be able to get a good tracing and not being able to read this EKG. There's been times where we've had to stop and at a stop sign or pull over so that we can actually read the EKG. So I find it easier, and other paramedics might find it easier, or you might find it easier in the hospital, to put those limb leads on the trunk itself. So up by the clavicles, down near the pelvis, you're actually going to decrease the chances for that artifact. Basic EKG class, autonomic nervous system. Again, here's a quick look at the layout of the heart as well as the pathway of blood through the heart, like we talked about a little bit earlier. Again, the coronary arteries, which are supplying oxygenated blood to the muscle of the heart. If we're looking at the electrical pathway of the heart, remember back I told you that the first node of the electrical pathway is the SA node, or the sinoatrial node. That node is located, I can't get my mouse to work. Okay, let's go back really quick. I apologize. The sinoatrial node is actually located here in the right atria, right? So this is actually depolarizing the atria, or starting that depolarization, and the SA node is smart enough to know that the beat should be between 60 to 100 beats a minute. Once this impulse gets down to the AV node, or the atrioventricular node, the AV node is actually slowing down this conduction, giving enough time for that heart to fill the ventricles with blood. This passes through the bundle of His, the bundle branches, and then down into the Purkinje fibers, right? And we have those bundle branches that are separating in between the left and right bundle branches down the septum. So our autonomic nervous system, the autonomic nervous system regulates the functions of all organs by the reflex and central nervous system control. The ganglia, located here, are what transmits and receives information from the heart and the circulatory system. The autonomic nervous system has the sympathetic and parasympathetic nervous system located in it. The sympathetic system produces norepinephrine, which is an adrenaline-like neurotransmitter that activates receptors called adrenergic receptors. The parasympathetic system secretes acetylcholine, which activates the cholinergic receptor site. So here you have your parasympathetic nervous system and your sympathetic nervous system, which is both part of our autonomic nervous system. In our sympathetic system, this activates beta-1 adrenergic receptors, which increases the rate of the SA node pacing, right? This is going to make it go a little bit faster, increases that rate of conduction, increases the force of contraction, and when I talk force of contraction, how hard the heart is actually pumping, and then the irritability of the foci. So the irritability would be how the nodes and how the foci points of the heart are actually receiving those impulses. The heart is stimulated by its terminal buttons. The buttons deliver norepi to the beta-1 adrenergic receptor sites, and norepi activates the beta-1 receptors, stimulating the SA node to pace faster, right? We see norepinephrine given in a hospital setting, and norepi activates those beta-1 receptors, stimulating the SA node to beat a little bit faster. It also improves the AV conduction through the atrial and ventricular myocardium. So it's actually helping that impulse get through the atrial and ventricular myocardium. It increases that force of contraction, which is actually making the heart pump harder. And epinephrine is also secreted and even more helps as a stimulator. The parasympathetic nerves release acetylcholine, which activates the cardiac cholinergic receptors to produce the cardiac inhibility effect. This decreases the heart rate, decreases the myocardial conduction, and depresses the AV node. This also decreases the force of contraction. So again, sympathetic nervous system or your parasympathetic nervous system, this is opposite of what we just learned, right? The sympathetic nervous system increases the rate of conduction. It increases your SA node pacing. It increases your force of contraction and increases how the electricity is actually getting across those membranes. The parasympathetic nervous system, on the opposite end of that, means that it's decreasing the rate of the SA node pacing, it's decreasing the rate of conduction, and it's decreasing the force of contraction and decreasing the irritability of atrial and junctional foci. The vagus nerves are the body's main parasympathetic pathway, and the vagal stimulation means parasympathetic stimulation. Okay, so this is when we also see nausea, vomiting, diarrhea. So, the autonomic nervous system controls blood flow and blood pressure by regulating constriction and dilation of arteries throughout the body. The sympathetic nervous system stimulation constricts arteries throughout this body, and the parasympathetic nervous system dilates the arteries. So if you look at this picture here, your sympathetic nervous system constricts these arteries, creating an increase in blood pressure, increase in heart rate, and increase in contractility. The parasympathetic nervous system is dilation of all of these. So again, fight or flight or rest or digest. Okay, sympathetic would be fight or flight, parasympathetic would be rest or digest. And we learn these in our careers, but this also applies to the cardiac cycle as well. So, severe pain and seeing blood is part of this parasympathetic response that causes syncope, right? We see people that can't stand the sight of blood and they pass out from it. That's part of their parasympathetic response. This slows down that SA node and causes bradycardia, right? bradycardia is a slow heart rate, and I said that our SA node is normally firing between 60 to 100 beats a minute. So if our parasympathetic nervous system is stimulated, this is actually going to slow that down. It causes our blood pressure to decrease, and it's also known as vasovagal syncope. Vagal maneuvers can be used to produce a response from the parasympathetic nervous system for diagnostic and therapeutic response. So we use vagal maneuvers specifically whenever we're talking about SVT or sinoventricular tachycardia. GI stimulation may produce a parasympathetic response as well, and carotid sinus massage may be used to produce a response. And we're going to be discussing this later in a couple of chapters, but be thinking about these vagal maneuvers and how we're using the parasympathetic nervous system to our advantage. So standing produces a compensatory sympathetic response that constricts those peripheral arteries to prevent distal blood pooling and stimulates that sinus pacing. So your SA node stimulation during sympathetic responses, especially whenever we stand up, it's going to say, hey, heart, you need to beat a little bit faster. So it's actually going to cause your heart to beat a little bit faster. It inhibits blood flow. And without this, we might see a little bit syncope, right? So if we're sitting in the recliner, we're relaxing, we're watching TV, and we stand up and we don't have this sympathetic response, this is when you start feeling lightheaded, you start having that orthostatic hypotension, you might actually have syncope whenever you pass out. And pooling of blood in the lower extremities happens during prolonged standing. So normal heart rate and blood pressure should increase, right? With some elderly patients, heart rate increases, but the blood pressure doesn't. So this causes stimulation of the parasympathetic system, and it causes them to actually pass out and have that pooling of blood. So this is neurocardiogenic syncope, right? It's a sympathetic response. So heart rate's increasing, blood pressure's not, and you start getting that syncope. So the autonomic nervous system is what we just learned about, and this is part of our body that is actually taking control, right? We don't have really any control over this. I don't have any control over how my arteries are constricting and dilating, and I don't really have any control over my heart rate, right? I can get myself worked up and increase my heart rate and blood pressure, but our body is doing this naturally. Welcome to Chapter 4 of the Basic EKG class. We're going to be talking about rate. So again, here's a layout of the heart, the pathway of blood through the heart, and then the coronary arteries. Here's the electrical pathway as a reminder. We start with the SA node. The SA node sends that signal across the myocardial membrane in the atria into the AV node that passes through the bundle of His, the bundle branches, and then the Purkinje fibers. So when we talk about rate, like I talked about earlier, SA node is our first primary pacemaker of the heart's electrical pathways. The SA node beats at a rate of 60 to 100 beats a minute, and it's in the upper posterior wall of the right atrium. If the SA node paces at a rate slower than 60, then it's considered sinus brady or sinus bradycardia. We often see this from excess parasympathetic stimulation, and it can reduce blood flow to the brain or eventually cause syncope. Sinus brady is only present if the SA node is producing a rhythm less than 60. So any beat that is sinus in nature that is less than 60 beats a minute is considered sinus bradycardia. Sinus tachycardia is when the SA node is producing a rhythm greater than 100 beats a minute. Tachy is fast and cardia is heart, so sinus tachycardia is greater than 100 beats a minute. Exercise can produce sympathetic stimulation, which causes the heart rate to be increased. There are other areas of the heart that we'll be discussing later that also can cause heart rates greater than 100. If the SA node fails to pace, the heart and the myocardium has the potential to create ectopic beats. Ectopic beats are easy to remember because it's when the heart is irritable. So when the heart is irritable, such as deprived of oxygen or decreased blood flow, then we get these ectopic sites where the heart actually creates a impulse in one specific area. So in this photo, you can see the SA node in the upper right atria where it's supposed to be, and there's three automatic foci in this area. So the heart is actually creating points that aren't within a node, but that are creating a beat. The atria has the potential to create these pacemakers, and this foci can take place distal to the SA node, closer to the AV node, and then in the Purkinje fibers as well. So this can happen at any place within the heart where the heart becomes irritable and has these irritable sites. The level of the foci have a general range of pacemaking, and each automaticity focuses on the atria as a specific rate, so 60 to 80. The AV junction paces at a rate of 40 to 60, and the ventricular automaticity foci all pace in the 20 to 40 per minute. So if you look at this photo up here, the atria, right, the upper part of the heart, should be pacing at a rate of 60 to 80 beats a minute. The AV junction, or where the AV node is, if this now becomes our primary pacemaker because the SA node has quit pacing or isn't pacing at the rate that it should be, the AV junction can actually take over as our primary pacemaker at a rate of 40 to 60 per minute. If we start getting slower and slower rates, and now the SA and the AV nodes both aren't producing impulses on their own, the ventricles can actually take over at a rate of 20 to 40 per minute. That's very, very slow. So again, atria 60 to 80, AV junction 40 to 60, and the ventricles are 20 to 40. Overdrive suppression is a characteristic of all centers of automaticity, and this makes sure that if the SA node is firing and functioning properly, then all the other areas should be suppressed and not fire, so that there's no competition. So on a normal, healthy heart, we should see the SA node firing at its rate of 60 to 80 regularly. Okay, if this were to fail, it's now going to start going down the line. Then we're going to see that overdrive suppression. So again, the SA node is not firing correctly, so now the junction is going to be taking over at 40 to 60, and then if that is not firing correctly, the ventricular foci are going to be taking over at a rate of 20 to 40, which is very slow. These are patients that we need to figure out the cause of why they might be this slow, why it's not functioning correctly. These are patients that we might be pacing, or patients that might get a pacemaker in a hospital. So in the case that the SA node fails again, then the next pacemaker site should kick in. So the SA node, if it fails, we're going to have atrial foci, and we're going to start seeing those ectopic sites that are going to start taking over as the primary pacemaker. Again, this should only take place if one of the higher area pacemakers fails and it's no longer functioning. So if the atrial foci is not properly pacing, then the junctional focus takes over and takes over responsibility. If the junctional focus takes over, then the ventricles are now going to take over. The atria has many different sites if the SA node were to fail. So your SA node fails, it's going to start creating a bunch of different sites. And if this were to happen, the atrial automaticity focus will take over as the dominant pacemaker. This would again suppress all those other sites, and this is at an inherent rate of 60 to 80 beats a minute. The AV junction acts the same, and like we talked about earlier, the AV junction or the AV node is primarily responsible for slowing down that impulse before the SA node fires and gets the impulse down to the ventricles. But if there's no pacing stimuli from the SA node, the AV node is going to take over. If there's no stimuli from the atria, then the AV node will take over primarily as the pacemaker site for the heart, and this rate is 40 to 60 beats a minute. These beats are called junctional beats, and just like we talked about earlier, you guys can think about the P wave, right? That short hump before the QRS complex. That is where your SA node is primarily seen. But if we have junctional beats, we're probably not going to be seeing a P wave in these rhythms. So if there is a complete block in the AV node, then there's no focus coming from above. So think about it, starting from the top, we have the SA node, then we have those ectopic sites, then we have the AV node. Now if the AV node is not functioning properly, we need to move further down. The rate should be 40 to 60, but if there's no focus, then it will be suppressed and will also not be functioning properly. But if we have a primary AV node function, our rate is going to be 40 to 60 per minute. Now, if the AV node fails, we're getting down into the ventricles. The ventricles also have that automaticity just like the atria does, and they can create a pacemaker between 20 to 40 beats a minute. This only takes place if all the other sites from above are not functioning. So this is a failsafe that our heart has. So the SA node's not firing, the AV node's not firing. We still need our heart to beat, so the ventricles are going to take over. Without any suppression from above, the Purkinje fibers kick in and produce an idioventricular rhythm, or IVR. This only takes place if the sites above are not pacing, or if there's a block somewhere from along the impulse to reach the site. There are 3 levels of backup pacing, like we talked about. So if the SA node is functioning, the rate should be 60 to 80. So the SA node 60 to 80. If not, the AV node takes over as the primary pacemaker. The AV node functioning properly should be 40 to 60 beats a minute. If not, the Purkinje fibers take over. If the ventricular Purkinje fibers are functioning properly, the rate should then be 20 to 40 beats a minute. So again, overdrive suppression. Think about it as fail-safes so that if your SA node's not firing, you still have backups to take over. With every EKG, you should be able to look at the strip and figure out the rate by the distance between the 2 QRS complexes. So, an easy way to do this, and these are numbers that are easy to remember, okay? So remember going back to those big boxes, right? We said they're 5 millimeters, okay? 5 millimeters is how we're measuring, okay? So find the first R wave that you want to look at. So here we have an R wave, okay? If our next R wave was right on this line, it'd be 300 beats a minute. If our R wave was 10 millimeters past that, it's going to be 150. And if our R wave is 15, it's going to be 100, 75, 60, 50, and so on. So a way that I like to remember is backwards. So say I have a R wave over here, okay? I'm going to start counting backwards, okay? Because it's easier to count up for me. So 50, 60, 75, 100, 150, 300, okay? But you're going to be counting R wave here, and instead of 50, it's now going to be 300, 150, 100, 75, 60, 50, 40, 30, and so on. So just remember, you can do it either way. Just flop this, okay? I like to do it backwards. That's just my personal preference. But I start with R wave here, line that up with the first solid black line or my first mark, And then I'm going to do 300, 150, 100, 75, 60, 50. And I'm actually going to be counting off. So if I have one that's 60, I should have 2 big boxes or 10 little boxes in between. When you find the next R wave, that determines your rate. If it falls on another black line, it's going to be easy for you. If it's not, you may need to make an educated guess. Okay, so here we're in between 75 and 100, right? We can't necessarily make certain what it is, but looking just primarily at the EKG, not at your patient, it's in between 75 and 100, so you can make an educated guess on what the difference is. So when we start looking at practice tracings, we're going to be asking ourselves these things. The rate seen here is what? So I'm going to start, this is a solid black line, okay, that's what this QRS falls on, so this is going to be easy for us to figure out the rate. We're going to go 300, 150, 100, 75, 60. Okay, so 60 beats a minute. This looks a little off though, right? So our T waves are inverted, and we'll talk about that later. They're upside down or with a negative deflection. If you notice there's no P waves, where did this QRS originate from? That's right, this QRS came from the AV node. Remember how I told you earlier that our P wave is caused by the SA node depolarization. If we do not have a P wave, then it's pretty safe to say that this is a slower rate, obviously by the distance between the two R waves, but this is probably originating from that AV node or that AV junction. So when we ask ourselves questions, when we look at every EKG, we should be asking each of these, and I'm going to ask you these multiple times as we go through this course. Is this rhythm regular or irregular? It's pretty safe to say that this is regular. Is there a P wave for every QRS? There's 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Yes. Is there a QRS for every P wave? Yes. Is there a QRS? Is there a QRS for every P wave? I don't know why that question's on there twice. What is the rate? So figuring out rate, these ones are kind of hard to see, but we're going to just make an educated guess. We're going to say that this is falling close to this black line, so 300, 150, 175, 60, below 60, so sinus Brady is probably what this rhythm is. It's less than 60, right? So that's bradycardic, and it is sinus in nature because we do have a P wave. What is our PR interval? PR interval going from beginning a P wave to our R wave. Our PR interval is short. We're just going to say short for now. And what is the QRS duration? This is a narrow complex, so we're going to say that this is narrow as well. Answering all of these questions is going to be able to allow you to effectively diagnose this rhythm, and not just this rhythm, but any rhythm. So asking yourself these questions as we move on is going to be very beneficial when figuring out what the rhythm is. So this is sinus Brady. Okay, so again, we're going to say that this one's pretty close to this solid line. 300, 150, 175, 60, 50, so around 50 beats a minute. There is a P wave for every QRS. There is a QRS for every P. Our PR interval looks good, and our QRS duration looks good as well. So we've determined 300, 150, 175, 60, 50, but what comes after that? On the top of the strip, there's black marks that show 3-second intervals. So you can see these little ticks at the top of these EKG strips that are actually 3 seconds. If you note the 6 seconds, okay, so we have 3 seconds here, 3 seconds here. This is a strip of 6 seconds right here. We can count the number of QRSs in that 6 seconds, then multiply by 10. It makes it very, very simple for us. So again, here's one black mark, 2 black marks, 3 black marks. Okay, so this space is 3 seconds, this space is 3 seconds. So we have 1, 2, 3. So this is about 30, there's 3 marks here. So 3 by 10, that's about 30 beats a minute. That's very, very, very slow. So if there's 4 QRS complexes in that 6 seconds, then you know the rate is 40. It's very simple. So again, each of those marks on that piece of paper is 3 seconds. So time to practice. We have one black, so we'll start with one black mark, one black mark. These are 6-second strips. So we can look at our rate here. Okay, so we have 1, 2, 3. So that's safe to say that number 1 is 30 beats a minute. Number 2, 1, 2, 3, 4, 5. So that's safe to say that this is about 50 beats a minute. And then number 3 is 1, 2, 3, 4, 5, 6. So this is about 60 beats a minute. If we wanted to do it with the 300, 150, 100 method, we could do the same. There's a black mark here and a black mark here, or it's on a line, excuse me. So 300, 150, 100, 75, 60, 50, 300, 150, 100, 75, 60, 50. So this one's about 50 beats a minute, in between 50 and 60. So what we've learned in this session is different heart rates within the cardiac system, how the cardiac systems work, and different rates of the SA node, AV node, and the ventricles. So you can go back, look at this, study it. It's okay. I know it's a whole lot of information to take in, but you guys have done a great job so far. Thank you for joining us for today's basic EKG class. Down below, you're going to find a link to a short test for today's session. If you have any questions again at any point, please feel free to contact me at 970-542-3570 or tfreeman@co.morgan.co.us. Thank you for joining us, and we hope you learned a lot.